Excuse me, ladies and gentlemen. Thank you for your patience in holding. We now have your presenters in conference. Please be aware each of your lines is in a listen-only mode. You may submit your questions electronically anytime by using the chat pod located to the right of your webinar platform. You may also download a copy of today's slides using the Files pod located below the slide presentation. It is now my pleasure to turn the conference over to today's first presenter, Chris Hund. Please go ahead.
Thank you so much. Hi, everybody. Welcome to the April 2021 AHA Team Training Monthly Webinar. This month's webinar is Design Thinking for Human-Centered Healthcare with our presenter, Jennifer Calzada. You'll be hearing from in a bit. I'd like to make note, too, that we are very generously sponsored today by Quality Reviews, and so you'll be hearing from Dr. Edward Shin in a second about that. Just a few announcements to get started here. You can listen to the audio two different ways. You can do so through your phone, but if you do that, make sure you mute your computer speakers so you don't get a weird feedback, or you can just listen through your computer. All the hyperlinks on the screen are active if you click them, and if you do that, it will just open up another window so you won't lose the webinar. And we will do Q&A at the end of the presentation. So please write questions in as we go in the chat box that you see on your screen. I'll gather those questions and then put them together, hopefully for a nice Q&A at the end of the presentation. Also, feel free to ask technical questions if you're having any sort of technical difficulties, and we'll make sure to help you out right away in that chat box. There is continuing education credit offered for this webinar. So to receive that credit, that 1 hour of credit, that is for all types of clinical backgrounds, you'll need to create a Duke OneLink account. And if you've already done that, you don't need to do it again. But if this is your first time with us, you will need to do that. And then 24 hours following this webinar, you will be able to text the code on your screen to the phone number you see on your screen. And we will put that code and phone number up again at the end of the presentation, so no worries. You'll also notice in the Files pod that you see on your screen right now, something that says Instructions for Webinar CE Credit. And that is very useful too if you just want to download that. Okay, some upcoming team training events. So webinars, we have a webinar May 12th. That's our next monthly webinar, and it is Culture, Team-Based Care, Improved Value. So join us for that next month. Virtual courses and workshops, you can currently register for a workshop that's called Improving Team Structure, Engaging Patients and Families as Team Members. And so that's a 4-week online workshop that will help guide you through the idea of how you bring in patients and families as part of the team. It's really important to do that, so consider joining that workshop. We also encourage you to join our online community platform called Mighty Network. So to do that, just click on that link and you'll get exclusive content and you'll be able to connect with your peers to share stories, to post things, to see new tools. It's a great platform. We have a lot of people on it, and so please consider joining it if you're interested in team training. I'd also like to point your attention to AHA's brand new Advancing Care Conference. This is a really exciting new conference that will be taking place in person in Chicago, October 4th through 6th. What makes this conference really neat, though, is that starting in August, we will open an online portion. You'll use design thinking techniques to plan your your route through the conference, understand how you can solve challenges at your health system, and then after the conference, you'll continue online to see how you did and to kind of help you chart a path to create a good elevator pitch for leadership about things you want to change, etc. So check out our website for more information. You could also apply right now to be a speaker. You could apply right now to be a sponsor. So there's all kinds of things that you could do on our website. but please check it out. It's really exciting, and like I said, it's a brand new experience. Okay, without further ado, I'd like to pass things off to our sponsor today, which is Quality Reviews, and I'll be tossing things over to Dr. Shin, who is the CEO and co-founder of the company, and so he'll say a few words. Dr. Shin?
Thank you, Chris, and thank you to the AHA for the opportunity to share what we do, and I'm looking forward to Jenny Calzada's talk on human-centered design. So I am the CEO, co-founder of Quality Reviews, and we, in a nutshell, help health systems improve patient experience through real-time feedback and service recovery. Very briefly, I know I just have a couple of minutes here, but how it works is we'll set up a HIPAA-secure ADT feed, or what they call an admission, discharge, and transfer feed with the health system. So using that data flow, we will text patients immediately after an episode of care, for example, an outpatient visit, a link to a survey that they can take right on their smartphone. And then all of that patient feedback is aggregated and displayed in real time on a web-based dashboard. It's also important to note that we have a whole suite of products that are built off of the same platform, so things like appointment reminders. We've developed a COVID screening tool to help screen patients in advance of in-person care. Transparency, where you can actually publish patient reviews on your health system's website, as well as an important engagement tool for employees, staff as well, because there's obviously a link between employee satisfaction and patient experience. Some notable clients: we've been around since 2012, and we are headquartered in New York City, so we can see here that we've got a good base of New York City clients, but we are all over the country in 8 states now, and some notable clients who've enjoyed good success with our tool, a number of whom have been with us for over 5 years and continue to expand. So that's it for us from Quality Reviews. Again, I'm looking forward to hearing Jenny speak, and if you do have any questions, please feel free to reach out to us. Appreciate that. Thank you.
Dr. Shin, thank you so much. Everybody, please, if you're interested, check out Quality Reviews. It seems like a wonderful program, and again, thank you very much to the support of Dr. Shin and Quality Reviews to help bring this webinar to everybody today. Okay, so today's presenter is Jennifer Calzada, who's the Director of Simulation at the Tulane School of Medicine in New Orleans, Louisiana. She is a Team Steps Master Trainer, a member of the AHA Center for Health Innovation Team Training Advisory Board, and is also certified in human-centered healthcare. So really excited to have her here today and to hear all about this. So I'm going to now turn things over to Jennifer Calzada.
Thank you, Chris, and good afternoon or good morning, everyone, depending on your time zone. So today we're here to talk about specifically what is this thing called human-centered healthcare and design thinking. We'll go through a few applications into healthcare systems. We will actually have a few examples of using these techniques specifically with healthcare systems, and then also describe how these techniques can integrate into your process management at your healthcare system, and very specifically into Team Steps, since obviously that's why most of us are here. So design thinking in human-centered healthcare. So we all know that health systems are complex and constantly changing, sometimes daily, and over the last 13 months for all of us, sometimes hourly, I'm sure. So there's changing regulations that may be coming from places like Joint Commission or the AHA, or it may be your own internal system regulations. And during COVID, that also includes possibly OSHA regulations and CDC regulations and FDA regulations. So you get the sense that just with that, things are complex. There's workforce changes in both the numbers of people due to retention issues and then also the makeup of your workforce. Think of the workers that you had in a hospital 30 years ago. A CRNA would not have existed. Really, all of the levels of nursing that we have today did not all exist. So sometimes just the makeup of that workforce changes and what their roles and their capabilities are. Employee expectations change, patient expectations especially change and are getting more complex due to competitive natures. Marketing from other healthcare systems in your area can sometimes force expectations upon your system. And then also just changing and mainly improving technology which will improve your capabilities. So put all these things together in a big soup and we are all dealing with a very complex industry. So normally when things happen and changes are going to happen in your system, I'm sure this is familiar to many of you. There may be a meeting of your senior leadership. You happen to walk by the boardroom, you see all the C-suite in there, and the next day your manager comes out and says, well, next week we're going to start doing whatever, and they announce some change. And you walk away from that meeting and many of you are thinking, well, who thought that was a good idea? And who did they ask? And why didn't they talk to us? We're the ones doing this every day. And unfortunately, this is the way many changes happen in business. And those are where really the business needs are being considered first and change is being pushed from the top down. In human-centered healthcare, or really in human-centered any type of change, we're saying you need to consider the individual human needs first and push change from the bottom up. So that's really what we're going to talk about for the next hour. So human-centered, if those of you who have seen this, if you've been, and hopefully all of you have, but if you have taken a Team Steps course, you will hopefully recognize this as the Team Steps icon, and you'll notice that patient, family, and the care team are all in the center. They're in the center of all the major tools for Team Steps because really all of those tools revolve around them. So in this sense, Team Steps definitely has it right. If you've taken the Master Trainer course, you're probably familiar with this image as well, looking at all of the different people involved in basically anything with a patient, different teams within your system, and then the patient himself. But, there are a few people missing from this chart. Now, I know Chris will probably tell me, just for graphic design reasons, it was easier just to call it the patient, but really that top triangle should be not only the patient, it should be the patient's family, it should be the patient's care team, which, their caregiver may not necessarily be family, but you really want everyone involved in that. So when you prioritize the human needs in healthcare, what that really means is the circle that I showed you previously where things were being pushed from the top down, we'd rather push them from the bottom up. So in a typical business-focused process change, if you are at a primary care clinic, your clinic administrator and really your health system you may have been involved in meetings where the topic is, how can we get more referrals for our surgeons? So our surgeons are not getting enough referrals from primary care. So how can we increase that? And what I'm really saying is if you look at this from a human focus, you should never be asking that question. You really should be saying, how can we ensure that our surgeons are providing the highest quality care to our patients? Because if we're doing that, referrals should follow. With all of the research that patients are able to do nowadays, it's not unusual for someone to be referred to a surgeon and say, well, I've done some research and I'd rather go to this person. So if you're focusing on the patients and providing the best quality care, that business should follow. So that's just a little bit of it seems like a small difference, but just that small change in perception and how you frame the problem will have impact on the results that you have coming out of there. Because you can see if you looked at this solely from the business side and said, how can we get more referrals? Your answer might be, well, let's just have them make more referrals. Because if we make more referrals, we'll get more patients. And yet, instead of looking at the reason of why aren't you getting as many referrals? So that was just a little sort of quick intro to the slight mental shifts that we're talking about when you're looking at the human needs first. I'm going to take sort of a step back and just talk a little bit about the sort of larger project of design thinking. So design thinking comes from system thinking, which is, it comes from like manufacturing and very large, high reliability industries. And it's basically a way of approaching any project of a complex system. Because the reason those systems are complex is because they have many, sometimes hundreds of interconnected parts. And when if let's say, for example, you work in the ED, you do not want to make a change to some process in the ED that is going to affect other parts of the hospital. And because hospitals are so interconnected, it would actually be very difficult to make a change in any one unit and not have upstream and downstream effects to the other units. So what we're saying is when you approach this from a system thinking standpoint, you consider all the components that are connected before you decide about any type of change in process, because you do not want to solve one problem and create other problems. They may not be problems in your unit, but they are still problems for your system. So again, this is a different way of looking at the previous circles I had showed you, but commonly what is done now, a top-down process. So the business need is the circle that has the number 1. It is considered first. And then technology and capability are considered because that is going to frame the limitations of what you can do. Obviously, it must be technically capable. And then the last thing is the human need. Now, hopefully, no one is ever making changes that would have negative effects on their patients, but we don't simply want to do things that aren't going to harm our patients. We really want to do things that are optimal for our patients. So looking at it that way, this is a quote from Tim Brown from IDEO, which are a major design thinking firm. Design thinking is a human-centered approach to innovation that draws from the designer's toolkit to integrate the needs of people, the possibilities of technology, and the requirements for business success. Now you notice in this quote, it started with the needs of people. So that's where I'm saying you need to flip your thinking and flip the process. Now the number 1 goes on the human need, and so the first thing that is considered is what are the human needs in this process, whether that's patients, it might be employees, whatever that is. And then we consider what is technologically capable, what is our system capable of doing. And then the last thing is, does this fit the business need? Now, by the same standpoint that I said business needs can't be harmful to patients, we also can't have human needs that are technically harmful to the business. Otherwise, we might not have a business. So while a human need, let's say for a primary care clinic, might be to have longer time with your primary care physician. In many cases, that is desired by both patients and their providers. There's obviously a limit there. We certainly couldn't have 1 patient per hour. I mean, there's no clinic that could stay in business at that rate. But, there needs to be some give and take there. But by considering the human need first, you are having more buy-in and empathy and having better outcomes at the end. So, again, talking about how many of these processes started with the business need, the first circle that was considered was the business need. Again, example I just mentioned, a clinical practice. Your clinic administrator, you may have had your monthly meeting talking about how things are going, and they say, we need to increase our top line revenue by 10%. So previously, an example for that, a way to do that is to increase revenue in a primary care clinic means to have more patients. And if you have a physical building that has 5 clinic rooms and you have 4 providers, you could add another provider. You could build more space. Obviously, both of those options have, significant revenue implications or expense implications. Or you can have more patients per provider, which is going to mean less time per patient. This is going to be familiar to many people in primary care. This is definitely a change that has been happening over the last probably decade or more. Now, design thinking says you should look from the human need first. So the physician and patient really want more time together for these appointments. It's going to improve patient satisfaction. It's going to improve patient outcomes. It's going to improve that patient-provider relationship. And so obviously these two examples are somewhat in conflict with each other. I will tell you this example is really what has given rise to the increase in concierge medicine in primary care, because they are built on the premise of we are intentionally reducing our number of patients and having more time per patient. There is obviously an added cost for those patients, but they have decided to prioritize that time per patient. So this is a real example in an acute care hospital in New York. So a major trauma center in New York, any of you who have been in the ED of a major trauma center in any city know that when a trauma call comes in, there is a flurry of activity before that patient arrives. The trauma bed's ready, all the supplies are stocked, and a very, very large team is generally ready to just jump in action. Now, trauma calls look like mass chaos, and somewhat are, and then to a certain extent that's by design. But one thing that has been common across all trauma calls is and it's the same as for code calls on a floor, is that communication amongst those team members is difficult. People all have specific roles. They're running in different directions. They're getting in people's way. They all tend to look in a blur. People are yelling out orders, and it can be chaos. So this hospital in New York made one change that was actually created by one of the nurses on the trauma team. The trauma leader for each call always wears a bright orange vest. Think of the vest that hunters wear so that they can be spotted compared to deer. That's what we're talking about. Now, if you have that leader standing in that room at the head of the bed in that giant orange vest, there is no problem seeing who is in charge, who is leading, and focusing on that person. There is, I will tell you at the end of this presentation, the references, there is a link to this article, so you can see more information, but they showed that this not only made their leader easier to identify, made them visible, but it improved communications across the team. And that was one very tiny, very simple change that was recommended by one of the people on the front line. So, I've given you sort of some ideas of how this all works, why, process changes should be done this way. This next section, we're going to talk about several tools to actually bring out some of these changes. So design thinking tools are by their nature visual-based. They certainly do come from the design field, and they're collaborative in nature. So they're used for managing all types of steps of change, visualizing the system itself and all its connected components and connections, to map stakeholders, to help build in empathy and buy-in at every step of your process, perhaps to reframe a challenge. If you have a challenge that is particularly complex or has been a chronic challenge, sometimes you just have to get people out of their traditional thinking. There are tools to help you envision what the change is, and then also tools to communicate this entire process that you've come up with and communicate that change. So the first one I have here should be reasonably familiar to most people. You may call it different things, a cluster map, a system map, but basically the concept is like I said from the very beginning, health systems are very complex, and most of the components are connected in some way. This is a way to help draw that. Now, that does not mean for any project you need to draw out your entire health system. I'm not asking you to do that. But what you would do is that very center circle that says topic, for the next several examples, I want everyone to think of if we were doing a project to increase the ED throughput in your hospital. So increase the speed that you're getting patients through. So if that is our topic in the middle, what do all those connected circles become? Obviously, there's going to be a cluster of circles for your ED staffing, the physicians, the nurses, all of your allied health people, your administration in the ED, and then you're going to have also connected circles for the cath lab, for your lab when you need to run blood work, for imaging when you need to get imaging work on patients, for admitting for the patients who may need to be admitted, for billing and insurance, for the OR and the PACU, and then may end up being the ICU or the med-surg, depending on the patient's status. You can see how just this one little change in one unit starts to branch out and affect more and more and more parts of the hospital. So if you increase the speed that you're putting patients through in your ED, can your cath lab and imaging handle a potential increased number of patients coming through there? Can admitting handle, what if we're admitting 3 more patients per day? So that is also going to affect the speed that you're discharging, because obviously you more than likely need to be discharging people to have room to admit people. So any project, as simple as it may seem, in a health system has the ability to just branch out and affect more and more units. So this tool just helps you visualize how close are those connections to those other areas, and it may mean that you need to bring some stakeholders on board to your project related to those areas. So this is another type of map, a causal loop map. It's a causal loop map, a little bit of a tongue twister. This is a little more detailed in that it's not just looking at connections, it's actually looking at causal connections. So this was just an example that I made up here. A reason that many health systems, since I've done teamwork, team steps for 11 years, I can tell you many come to this because of not only communications and teamwork failures, but also increased adverse events. Well, very often those increased adverse events are due to those communication and teamwork failures. And then that will, over time, if it's not addressed, lower your staff morale. That may also reduce your staff retention. All of these things, depending on the adverse events, can increase uninsured costs, and this entire loop becomes a feedback loop. And your problems can get worse and worse unless they're dealt with. So this is considered a causal loop. These are a few more. I'm not going to go into great details on all of these, but these are several more examples of just types of system mapping. Iceberg model, any of you who have taken team steps know that that is a big component and talked about during team steps. Behavior over time graphs, that is something where you're looking at, if we go back to the ED example, a common problem in the ED is especially on weekends, let's say in major cities, ED wait times can be longer. And patients certainly have very common behaviors as that length of wait increases. So one common thing that helps in EDs is to keep patients informed about what the wait time is as it changes, the reason for changes. So one thing you may look at is those patients' behavior over time. When is the best point that you need to re-engage that patient and just communicate with them, hey, the wait's going to be about 30 minutes more. You know, we just had a major trauma case come in. These are all different. You can certainly, I have links at the very end to a lot of design thinking websites. You can get more information on all these different types of system maps. Regardless of how you map your system, one thing you definitely want to do for any project is think about your stakeholders. Now, a stakeholder is, as it sounds, anyone who has a stake in whatever your project is. Again, back to our ED example, that is obviously everyone who works in the ED. That is obviously hospital administration. But as we said, there may be stakeholders in other units that really should have a say in your project. If you're an ED that has a large number of trauma cases, probably radiology is going to have a stake in that because you're sending a lot of patients for imaging. So you look at, in the stakeholder map, there are 3 different levels of stakeholders. Who is at the center of your experience? So if you're trying to increase the speed that you're getting patients through your ED, your patients are at the center coming through your ED. Who has direct influence on that experience? Your direct influence people in this example would be your physicians and your nurses and your ED staff. Who has indirect influence, and that is really the next ring of units. It might be the EMS units that are bringing your patients there. It's definitely going to be your imaging people, your lab, how fast you're getting lab values back because the patient is just sitting there waiting for that. Your cath lab people. So all of these are then your indirect influences on that experience of how much time an ED patient spends with you. So doing these type of maps for any project is then helpful to get input from all of these different types of stakeholders. One way to get input from stakeholders is you can do stakeholder interviews. Now it will definitely take more time because these are often done one-on-one or at least with an individual stakeholder at a time, but they provide deep qualitative data, especially at the early stages of change. So you may go to someone from your imaging department and sit down with them and say, talk through us about the example of when ED patients come through and how you can manage them coming through. What if they were coming through faster per hour? You're talking through the whole process with that stakeholder and identifying their needs in this project and also their goals. So, and by including them very early in this process of managing a change, you're building some trust with them that, first of all, this project is not going to have an outcome that is going to have negative impact on their area. The example I listed here, so if you're going to change the pre-op process, what stakeholders would you think you need to provide input? Now, obviously, you're going to think, well, certainly our surgeons and anesthesia and the residents and all of the staff that are inside the OR, that's the obvious ones, but also admitting, patient registration, financial billing and insurance, the patients themselves, the patient's family, patient transport. These are all, you can have a larger and larger list of people who can be impacted by one simple process change. Empathy map is a really great tool to very much get in the head of someone who is at the center of that stakeholder map. So for many things that we're doing in healthcare, quite often that center is going to be a patient. So for an empathy map, think about how many times in a meeting you've heard someone say that we're doing something, well, because patients want us to do this. How do we know that? And what do we know about what patients really want? So by doing an empathy map, you're making a team go through the process of actually documenting and thinking through and writing down the needs of that patient. Not only just patient wants us to do X, but why do they want it? What do they think about this process? What do they hear? What do they see? What do they say? Think about many of our hospitals, there are those sometimes spaghetti-looking maps on the floor to try and guide patients through a hospital. So you can look at it from the standpoint of we are doing this to help patients when they're lost, to help them find their way. But really, we actually should be doing things so that patients are never lost in the first place. So think about when a patient enters your building, which is unfamiliar to them, And what do they see? What do they hear? Is it a part of the hospital that is exceptionally loud and chaotic? What do they feel? What do they do? It really is putting yourself in the head of that primary stakeholder, which in this case is the patient. Shadowing is another way to get really detailed information, especially from your staff. Now, I will caution you, if you're going to do this with patients, you definitely need to be careful with that and obviously be HIPAA compliant with all the information that you're going to be collecting. But the purpose of shadowing is that you're going to observe someone in their real environment. And the reason you're doing this is because if you asked any of your frontline employees, so if you went to your admitting office and said, write down all the steps that you do when you're admitting a patient, it's very possible that there are a few small things that they do that they would omit from that list, not intentionally, but because they are so rote to them doing them every day, they don't even think about the fact that that was a step. And yet someone observing them, not being as familiar with it, will observe things in much greater detail than the person who is actually doing it. So if you're trying to change a process that may be relatively complex, you may want to have someone shadow those people because they're going to pick up those automatic steps that the actual people doing the job, as humans, we just do things without even thinking about it. Think of trying to teach your teenager how to drive. This is basically that. There are a lot of things we all do when we drive that we don't consciously think about. So another large way to do this is design workshops. Now, this is the collaborative part, I will tell you, of design thinking. So they can also be called co-creation workshops. So once you've done some of these things like some stakeholder interviews, perhaps some shadowing, and you've collected some data about your process up front, you want to have a team to start going through this and deciding what's important and what maybe needs to be changed. So it is ideal to have many of the stakeholders from various levels involved and put them together in a room for a design workshop. So an example of this, the neuro ICU. They're going to create some new ICU policies. You want to have members of that unit all involved in creating it. But we don't want to send these members into their little discipline-based teams doing this on their own. We want to have these people do them together. So you're going to bring them in together, focus on the problem, not only these frontline people, but also some decision makers, to then come out with processes that are basically co-created by the group. So a few tools that you can use within this co-creation workshop. One of the most powerful things you can do is called how might we statements. And it's basically utilizing language that it is not saying should we, it is not saying should implies judgment, could implies capabilities. It is just saying how might we. If we were to change something, how might we do it? So it's trying to eliminate some of your mental limitations. It is implying that there is a solution out there, that we just need to find the right one. So we've been talking a lot about ED wait times. How might we reduce ED wait times by 25%? So when you are just doing that, saying that is going to bring out lots of different suggestions from a group. So you're going to have all of these different ideas, and I know many of you are familiar with meetings where you may give a stack of Post-it notes to people and say, write all of your ideas down and let's just stick them on the wall. And that's great, but reframing a challenge is an exercise that does this in a little more structured way. So reframing a challenge means you're putting everything in this how might we statement, but then you're looking at it from a slightly different way. So I'm going to show you an image that's going to look like a messy tool, but I'll explain it. So this image on the right basically is an example of reframing a challenge with how might we statements. Now that squiggly line that you can see on the white paper kind of across the horizontal middle. So you're looking at that. In this example, your how might we statement was how might we reduce ED wait times by 25%. All of the Post-it notes that people would put above that line are why do we want to achieve this goal. So it might be it will improve patient satisfaction if they don't have to wait as long. It might be that we can see more patients and help more patients. I know that's two different sides of the same coin, but there are two different reasons. So it might be that we can, cardiac patients that come in, we can get them to the cath lab faster. Trauma patients who come in, maybe we get them to the OR faster. So these are also improving patient safety. So that you're going to have lots of reasons above the line of, if we do this, why are we doing this? And then you're going to look at what are all the reasons that we're not currently doing this. Well, you know, it might be the unpredictability of when patients are coming in. I mean, that is just the nature of the ED. So there also might be issues of we can't send more than one person to the cath lab at a time, or the limitation of the number of patients who can go to imaging at a time. Right now, there may be extra COVID limitations on patient capacity. Some of the things that stop us from getting people through the ED faster might be our hospital is nearly full. We can't discharge people fast enough to admit new people. So you're looking at all of these different reasons for why you should do something and why aren't you doing it right now? What's stopping you? And by just taking that random stream of thought that groups often have in a meeting and focusing them in a different way, as you'll be able to come up hopefully with new creative ideas. You might see patterns emerge. There might be many patterns. For example, many of the patterns in, again, speeding up an ED have to do with capacity. So now it may be getting you focused in on, well, perhaps we need to look at ways to increase our capacity because it's often capacity issues. So it's just a way of sort of harnessing people's thinking around a specific project. A playbook is sort of the last big tool, and it's really the big one at the end. If those of you who have gone through Team Steps master training, you know that at the end, at day 2, when you're starting to work on the implementation idea for your project, in the Team Steps manual, or I guess it's a CD now, there is an action plan. It's about, if I remember correctly, 45 pages, I believe. It's very long. It's very text-heavy. It honestly looks like taking a test, and that's a little bit how it feels. So a playbook is that same concept. It is your action plan for what you're going to do for your project, but it is not 45 pages of text and fill in the blank. It is many of these tools that we've just talked about for the last 20 minutes. The playbook basically encapsulates everything that your team talked about, all your research you did, your qualitative research from your stakeholder interviews, your research from your shadowing, well, and also any research that you've already done. You may have patient surveys or employee surveys that fed into this. It takes all of the options that your team considered, like what are all the options we considered, and here's the reason why we didn't pick these, and here's the reasons why we're recommending the one we are. And then it talks about the steps to implementation, and those steps may be different for different stakeholder levels. Back to our ED example, the steps that may be taken by people within the ED may be different and probably more extensive than those other units that are affected somewhat but not directly. So the playbook is like your big presentation at the end of your final recommendation and all of your action steps to get to your goal. It just hopefully is more visual and collaborative than just, you know, the typical Team Steps action plan. So those of you, especially those of you who are Team Steps master trainers already, if you feel like we've been talking about the Team Steps change management module for the last 20 minutes, then you're really right. because design thinking is just a process to manage change. It's just focused on being a little more collaborative and focused very much on putting the humans first in considering those change, but it is actually very similar to any type of change management process. So, very much a goal in team steps is, and it's what we talk about a lot on day 2 in the Master Trainer, is creating a culture of safety. A lot of these principles and a lot of these tools that I just showed you are great tools to use to manage any process to get you towards changing that culture. And we all know, and those of you who are Master Trainers, we all teach everyone that you don't change a culture overnight, and changing a culture across your entire health system is a very large project. So taking a lot of these tools, building empathy, getting buy-in from people from different roles and different levels of stakeholders very early will actually improve your success for any culture change. Basically, if you're keeping the focus of the humans, whether it's the patients and also your staff, if that is really the focus of your change, you're helping to ensure that the buy-in is already built in by the time you even release what your change is. So some of the specific tools that we talked about that actually integrate, they all integrate very well, some of them exceptionally well into team steps. The system cluster map, as I said, every health system, no matter how big or small you are, is complex. So doing a cluster map is actually very valuable to figure out those levels of stakeholders. Interconnected circles or causal loops are very useful in identifying connections and the effects for your change. Some of you may, just from having run many Team Steps courses, I know people sometimes come with a specific problem in their unit that they want to solve, and doing a causal loop may make you realize that perhaps there are other units or areas that are involved in that you're not considering, that you need to bring in as stakeholders. And then once you've identified those stakeholders, interviewing and shadowing, again, will help give you early feedback and buy-in, but it also builds your research. And then the design workshop or co-creation workshop is where you should bring everyone together for collaboration to figure out what really is your final process, and what is your final process to help get you to that culture of safety. And then your playbook will help guide your rollout and your action steps. And specifically on playbooks, at the end, if you download the slide webinars, I do have about 4 or 5 examples of healthcare-specific playbooks that you can, some of them you can download, some of them are online-based. That would be a great way to roll out a big culture change to your health system, is have an online living playbook. Because as you roll out things to one unit, things may slightly change just based on the experience with one unit. And so if you keep it online for everyone to see, that really increases buy-in and improves your communication across your health system. So these are just a few examples of how you can integrate this into team steps. But really the biggest thing is to just shift your thinking of starting with that human need first, and then it will follow through to satisfying the business need. Just making that one mental shift helps improve any of your process changes. So, really the conclusion, like I said, these are visual tools that are collaborative by nature. These will help you keep the human needs in focus, and with taking these design thinking tools and integrating them into team steps, you're really going to benefit from both tools. The team steps tools that specifically help you communicate, and some of these design thinking tools that will help you communicate the change. You will have hopefully a better culture of safety at your health system. So I will turn this back over to Chris for any questions. I will come back to this for anyone that wants it, but I'm just going to click forward and show you. So these are the healthcare playbook examples. These are all linked, so you can get them. These are two websites, IDEO, which I mentioned, and a couple others that have a lot of design thinking tools. I mean, there are many more than I could even mention. And then lastly, any of you who are interested, the Human-Centered Healthcare Certificate is actually done by the New School in New York, so there is a link to that if you're interested in that. Chris, I turn it back to you.
Yeah. Thank you so much. That was great. Thank you very much. Yeah, I think the questions, content-wise, I've seen a couple of, are generally around the idea of, healthcare is so much about, potentially putting the cart before the horse, right? Growing a service line instead of thinking about the struggles that patients might be having with accessing care or with wait times or anything like that. So how do you culturally, I guess the big question is, how do you make this change to get people thinking the way you are? To get people to start looking at it from that perspective as opposed to the way we currently think about things?
Well, if I had that answer truly, I don't think I'd be doing this job. Let's all admit, if we could all answer these things easily in black and white, we'd be doing a lot bigger things. Honestly, it's that I will say the same answer that we tell people in team steps. You absolutely must have the buy-in and support from your most senior leadership, or any of these things are destined to fail. Whether it's thinking this way or whether it's team steps, if you don't have the support from the top, that's what you absolutely need. I will tell you that one of the best health systems for this way of thinking, and actually many of the instructors at the New School all come from Memorial Sloan Kettering. I mean, they're obviously one of the premier hospital health systems, in the world, and they even have an entire innovation and design division. So, it shows you that, even some of the best in the business are thinking this way. But honestly, you have to get someone at the top to really support it, and that's the same for team steps or anything.
Yeah, I feel like there is, there needs to be obviously time and resources even dedicated to thinking this way. It's important to have those moments, to have those resources for innovation put aside and not just saying, oh, this is your job as well to people. So, yeah. I'm looking at, so you're just getting a lot of wonderful comments here. One thing that came in about the healthcare facility that's good with this, that's Memorial Sloan Kettering is what she said. Let's see. Oh, and you just commented that. All right. Somebody's asking, if there is any sort of case studies that you know of with data available to help with this, or to help get people to understand that this is the right thing to do.
A number of those playbooks, like all the playbook examples I included here, were health systems, and a number of them do have some very extensive research data in there. So I would certainly start through and look at some of those. You may also just want to look at, Memorial Sloan Kettering. Like I said, they have an entire division that deals with these things. Just look at their story of, how and why they came to this. Obviously, they see huge value in it. So.
Right. Yeah, and I think that when I've been, involved with, when I first started getting involved with this type of work at the AHA, I think it makes people think, oh, what's this? Oh, design. Oh, that's not the kind of person I am. But it's really, a process of, following some of these playbooks, looking at some of these tools and realizing that, if you have a pen and you have some sort of playbook or template, you just need your brain. And it's something that I think has a very, can get complicated, but really the low bar of entry. Anybody can do this, and anybody can go in and start thinking this way. So I think it's exciting stuff to bring to the field.
Yeah, I would agree. I'm sure there would be a lot of, if you invited a lot of healthcare professionals to a meeting and said, we're going to do a design co-creation workshop, that you'd probably first get a lot of groans, and then get a lot of people saying, I'm not for this, and yet you're right, they are, because they're the ones who are doing the job that you need to get information from, who have the ideas. Think of how many people, as they're doing their job, either comment to their colleague or think through their head, why hasn't anybody thought of, whatever, that?
Right.
And so it's those things that you need, their information and their ideas, and really once you have that, that's what gives you good outcomes. Now, I will admit a lot of these playbooks are, beautiful to look at and clearly had some great marketing people put them together, but that's not what sells your idea. What sells your idea is that it feels authentic to your employees, and that it is truly putting your patients and your staff and their needs first.
It is. It is a great way. You were talking about change management earlier, and this is a great way as well for giving people that feeling of ownership, and how ownership and feeling like you're a part of the solution is so much more impactful than buy-in, than somebody just saying, I want your buy-in and you're going to do what I want no matter what. Just get on board. So it's huge for that, I think. Yeah.
Yeah. If you say things and you plan things that feel authentic to your staff, and that feel like you actually understand that not only their roles but their concerns, and then present ways to address those, that is buy-in, rather than, then you're creating the buy-in instead of demanding the buy-in.
Right. There's a question, I'll kind of keep this as our last question here, from Eileen Alexander, if you see that one, that says, are there some networks that connect clinical systems to academics that have that kind of experience in this work? Like, just even, do you know of anything? Was there anything when you were, going through the new school where they're trying to make connections for people, either on, networks or socially? I'll plug and say, please join Mighty Network, and we can connect you, design thinking people that are interested in this that we know of. But anything more formal that you know of?
No, great question, and there isn't anything specific that I know of. I guess my best answer would be maybe we need to create that at the AHA Care Innovation Conference in October.
What a great plug. What a great segue you've got there. So I was going to say, to close this, is that if you liked this presentation, if you like this presentation, this is exactly how we are organizing the new Advancing Care Conference. Sorry, my allergies are kicking in at the wrong time. This is exactly how we are organizing the American Hospital Association Center for Health Innovation Advancing Care Conference, which is going to be later this year. So head on over and check that out, because it's about design thinking. We'll take you all through that process of design thinking. And then as you go through the conference, those will be those nuggets, those great moments, that great content that will help you fill out your plan. So if you're interested, please come check it out. I'd like to close to remind folks to please do evaluations when you receive them from us, to make sure you take care of your continuing education. Create that Duke OneLink account if you need to do that. And then on screen right now, as promised, is that code again, as well as the phone number. I'd like to also thank our sponsor today, Quality Reviews, and our guest, Dr. Edward Shin. And then a very special thank you to Jennifer Calzada of Tulane University for coming in and giving us a hand here today and doing a wonderful presentation. So thank you all for attending.
Thank you, ladies and gentlemen. This concludes today's webinar. You may disconnect your phone lines, log off the webinar, and have a great day.